I would like to thank the organizers for their kind invitation. And I think our studies aiming to look at the epidemiology of HS in the UK population. I think so I've recently moved from Cardiff in the UK, where I was head of dermatology for the last 7 years, to lead the dermatology program at University of Toronto. So it's actually work done in Britain, so previous to my time on this side of the Atlantic. Much of this research has been led by John Ingram. Some of you maybe know John from some of his publication and his work, and so I have to mention him because he's obviously a key driver in this project, and he was part of my group in the UK as a senior lecturer. So I've been on advisory boards of certain companies. You can see the list, but I have no equities, so I have some conflicts. And we used to have a lot of sponsored trials and so on in my department in the UK. I'll go very briefly with that. Afsane, I think, did a great introduction with all the different phenotypes, but as we know, HS is a complex disease. Has a very large impact on the quality of life. And one point I want to highlight, the pointer is not very strong, is the clinical disease definition. I mean, when do we define that it's hidradenitis? And that's key for this type of trials where you, studies where you try to understand the epidemiology. So what we decided is that and I think it's a consensus that obviously you have characteristic lesions such as boils in the folds, but we know it's more complex than that, and there's a number of boils that you need to have the definition of HS, and we decided from consensus, and I think from the European groups as well, that 5 boils in the fold is definitive of an HS diagnosis. And what's interesting is for a disease that is actually fairly easy to diagnose, as I think you mentioned, we can pretty much easily diagnose HS. Why is the prevalence so uncertain? And for instance, Gregor Jemek in Denmark decided that if you examine people in person, 4% of the population has HS. And then you have other studies, including this one from the US, from patient insurance claims, and it's a much, much, much lower number. So what's the true burden? And that's where we started. So the method was to analyze in the UK. We're fortunate to have a very strong database in primary care from many of the residents, and that's the CPRD. It has diagnoses, treatment codes, and so on. It's all recorded, so it's really a quite unique resource to probe into diseases. And what we decided to do is, obviously it's easy to get the codes for people who have diagnosis of HS, particularly if they've been seen by dermatologists, but what's harder is we know that the HS is very much underdiagnosed in primary care, and we have a lot of patients that have been waiting 10 years before they get a diagnosis. They see a dermatologist, finally they get a diagnosis. So how do you diagnose these cases who are having HS but have not been identified in primary care as HS? So we decided that any patient that would have more than 5 boils and antibiotics in the absence of another known skin disease, such as eczema or skin ulcers, would be a case of HS, which is a proxy case, if you like. And then we validated the algorithm we developed by sending questionnaires to relevant GPs to validate, if you like, the prevalence. So I think it's quite a robust method to identify not only patients that are already diagnosed by specialists, but also patients that are not yet diagnosed. And so this is the algorithm you can see. So you have 5 boils in unspecified sites, or 5 boils including several inflexural areas, and then this is typically HS cases, more than 5 boils in flexural positions. And so the validation questionnaire, I go very briefly through that, but basically has the patient experience painful lesions of the skin? Were they predominantly located in flexural sites? Have they had at least 5 of these lesions since the age of 10? And then does your patient have rope-like scar and so on, sinuses, etc.? And so GPs filled in these questionnaires, and we got a fairly good success rate at getting back. I'll skip the statistics. We did that in collaboration with University of Bristol, who has a lot of experience in epidemiological studies, and they use this type of algorithm. Don't ask me the details. It's in the publications, it's in press, so you can check, and we can discuss that separately. The results actually were that if we identify the number of cases that had this is all the sections basically that we could identify, and then with the total number of patients. We had patients with this description, and then patients with all the different descriptions that I think most dermatologists would agree this fits with HS. Again, the detail is in the publication. And so the validation was good. We had about 64% of questionnaires returned, and globally it confirmed the cases we had identified in probing the database. And so I'll go to the data. The prevalence, we had 4 million individuals in the database, so it's a very large number of patients, and we did document, we identified 23,000 patients who were already diagnosed. So that's the cases that were identified in the database as HS patients. But what was interesting is that 68,000 patients were proxy cases, so about 3 times more patients were undiagnosed. And I think to most of us, that doesn't come as a huge surprise. I mean, I think a third of the patients probably, or even a quarter, are diagnosed. The rest is sort of in the community. They may have been treated a few times. They may have reported it or not, but they may not have seen a specialist yet. We could validate some, and so the overall prevalence was 7.7 per 1,000, so that's significantly higher. It's 0.7% basically of the population, so it's much higher than the recent papers, I think, in a JAD, and I think some of this will be discussed here. And that's, you know, maybe something that's worth discussing here. I think we're always, that's one of the basic facts when you write a grant. You know, I was telling that to Afsane, and we've been debating that. What is the prevalence? You know, how frequent is the disease? It's a key point for funders, for instance, how much of the population is affected. And it's frustrating, I think, that after so many years of people studying HS, we still have relatively imprecise numbers. I think this is closer to the truth, and the overall prevalence is probably in the range of 1%. If we take the cases that have slightly less than 5 boils, maybe 4, then you go about to 1%. So I think that's closer to what we would have as a clinical definition. At least that's for the British population, and we know there may be genetic differences and so on, so the prevalence may be different in different countries. The rest of the data is really not that surprising. There's a ratio of about 3 to 1 women to men, so that's similar to what has been reported elsewhere. We can see the prevalence by age. You have all the details here. There's a peak around 30 to 40, but it can happen in all different age groups, even very early. That's the incidence. We had the incidence per 100,000. We did not see an increase over the years, so there's not like some other diseases. I think in cutaneous lymphomas, for instance, there's an increase now in prevalence that is described compared to maybe the 90s, whereas in HS we don't see that trend, at least in the British population. It seems relatively stable. There were some reasons that more patients, I think, were enrolled initially, so there may be some variation due to the way the database was built rather than true changes in the incidence. What we found, what was interesting as well, it allowed us to probe very efficiently comorbidities and with high p-values, so we can see obesity. Again, not a surprise. That's a good internal control, obviously, for our smoking is a big factor, and this is well known. And then I think we discussed hyperlipidemia, so completely agree with that one. There's a significant increase. We also see a very significant increased association with pilonidal sinus, so that's been discussed, with acne, and with Crohn's disease, as well as depression. What we don't see is an increased association with ulcerative colitis, which others have reported, so we don't think it's a very significant association, and we don't see an increased association with PCOS, which was also reported before. But that's again in our cohort, but it's 4 million people, so it's a pretty significant number. So in conclusions, we have a validated prevalence of 0.8 7%, so close to 1% really. We think the upper limit of possible HS prevalence, I've tried to explain a little bit the methodology, is about 1%. And that is in agreement with some of the questionnaires. So it's about tenfold more, I believe, than some of the recent studies that were published in the JAD, or 5 to 10 times more. And I think it's probably closer to the reality, but the overall female-to-male ratio is about 3 to 1. And as I mentioned, it's associated with obesity, smoking, hyperlipidemia, pylonella, sinus, acne, Crohn's disease, and depression. And we did not see an association with ulcerative colitis or PCOS. I don't know about diabetes. I think somewhere in the paper, I think. I don't have it here. So this is John Ingram. He led the study, and he's first author in the publication that is now in press at the British Journal of Dermatology. These are our collaborators. We had collaborators for the data extraction from CPRD, from Pharma Intelligence. The data analysis, the statistics were provided by the University of Bristol, Dr. Knipe. And I was overseeing the project, and these are our funders. It was largely funded by a grant from the Welsh government. And that was our previous institution. So if you hear more about Cardiff and hidradenitis, it's a nice city to visit. That's where I was before. And that's where we are now. That's the Women's College Hospital. So please come to Toronto next year. It's a great city. You will enjoy it, I'm sure. Thank you. Thank you.